Hey everyone, I'm your host Adrian. We do content like this weekly, so hit the subscribe button and ring the bell to get notified. If you want more content like this, click the like button and please leave a comment. Thanks again for watching. Welcome everybody from around the world today to today's Rupa Live class presented by Rupa University, the best way to learn about specialty lab work from industry experts. My name is Adrian Martinez, and I will be your host for this afternoon session. Today we have a very, very special guest with Dr. Jacqueline Smeaton here to talk to us about mastering the menstrual cycle, a truly comprehensive lab assessment of female reproductive hormones with Dutch. Before jumping in, a couple of quick housekeeping items. Everyone joining will be muted by default, but if you have any questions, go ahead and use that Q&A button located down in your menu bar, and we'll host a live Q&A session with Dr. Smeaton at the end of the presentation. Immediately following the Q&A, yours truly will show you exactly how to order this test directly on Rupa Health. And if you have to jump early, no worries. We are recording this session as we always do, and you'll be able to find it on rupauniversity.com within the coming days. As well, I'll go ahead and send out an email version of it so you'll have it right within your inbox. And if you are a fan of this type of content, be sure to check out rupauniversity.com to get access to all the previous sessions that we have done, including those with Dr. Smeaton. So with that, let's go ahead and jump in. I'd like to introduce your presenter for today. Dr. Smeaton is a naturopathic physician focused on infertility, reproductive, and genitourinary health. That one gave me trouble last time. I worked on it. In addition to her private practice, Hello Fertility, she is a prolific teacher in the field of reproductive endocrinology and hormones and has trained thousands of clinicians on her treatment methodology. Dr. Smeaton is a 2007 graduate of Bastyr University and has led a diverse career, including private practice, leadership positions, including president of the American Association of Naturopathic Physicians, and working across the functional medicine industry. In 2022, she took the new role as the Chief Medical Officer for Precision Analytical, makers of the Dutch test. Thank you so much for joining us today, Dr. Smeaton. I will go ahead and let you take it from here.
Awesome. And thanks, Adrian, for having me. And welcome, everybody. I saw a couple of you from Boston, which is where I'm from. It's a gorgeous day here today, and I had to close my door so I don't hear my kids playing outside. But welcome to all of you from all over the world. So let me go ahead and get my slides up for you all. Here we go. So I'm so excited to cover this topic because it's really foundational for anything in women's health to be able to evaluate a patient's menstrual cycle effectively. So what we're going to be talking about is how to really master lab assessment of the menstrual cycle. Now, I am on the team at Dutch now, very excited to join their team because I'm so excited about the work that they do. And I've been a raving fan customer for such a long time. And so we will talk about how I use Dutch testing in my practice, but it's not just a sales pitch. I'm going to put it for you in perspective with everything else that I do, because the Dutch testing is not the only thing that I do when I'm thinking about working up the menstrual cycle. So today we're going to review the normal hormonal cycle and talk about how various hormones shift throughout the cycle. So a little bit of a primer, make sure we're all on the same page from a physiology perspective. Then we'll talk about how and when you can measure various female reproductive hormones, including kind of the pros and cons of serum, urine, and salivary assessment for hormones. I want you to leave with a really clear clinical approach to how to evaluate the menstrual cycle. And so we're going to go through that in detail. And I'll talk about the tests that I prefer to use in my own practice and how I interpret them to really extract the most info. I think I have almost 80 slides. So I'm going to have to go quickly on some of these, but Adrian said he would email out the slides for you all if you want to spend more time with them. So let's talk about the menstrual cycle first. So, we break the menstrual cycle up into basically 4 phases. We have the follicular phase. The very first day of the menstrual cycle of the period, is counted as day 1 of the cycle. So that's the first day of full flow. So if you have patients who start their periods with spotting, that doesn't count. It's full flow. And this is important because this is how we'll count lab testing. So I want to make sure you're really aware of that. It's not spotting, it's not first day blood shows up, it's first day of full flow. That's the start of the follicular phase. Now, as this name implies, it's called this because what happens during this time is follicles start to mature and get ready to release. And hormonally during this phase, at the very beginning, hormone levels are actually quite low, really at their lowest throughout the whole cycle. And then around cycle day 7, those juicy follicles, as they start to be stimulated, start to produce estradiol. And so you'll see estrogen start to rise around day 7. So the follicular phase really is around day 1 to 13 of the cycle. And what you mainly have going on here is FSH coming from the brain, which is stimulating the ovaries to produce estrogen and produce follicles. Okay, then you have estradiol, which begins to rise, reaching a peak around day 14 if it's a 28-day cycle. That next phase would be that just a couple days around ovulation. So what happens is when that estradiol climbs high enough, the brain senses, oh, all right, we're ready. We got this egg. It's totally ready to go. Let's flip that switch. And that estradiol surge, which is made by the mature egg or the follicle, sends feedback to the brain and causes the pituitary to switch from making making FSH to making LH. Okay, that release of LH triggers ovulation about 10 to 12 hours later. Now, this phase lasts just around a day, and the main hormone we see here surging is LH. Now, LH is what women can detect on ovulation predictor kits. So if they're peeing on the test strips, it's detecting an LH surge. The second half of the cycle is called the luteal phase, and this is really because it's dictated by corpus luteum. So once that egg ruptures from the follicle, the residual sac, which is called the corpus luteum, starts to produce a large amount of progesterone. And this is triggered by the hormone LH from the brain. Estradiol will start to rise again also in the luteal phase, but it's kind of partnered with this big surge in progesterone. And that actually helps the estrogen and progesterone in combination, help support the integrity of the endometrial lining. Because remember, I didn't talk about this in the first half, but estrogen is responsible for thickening the lining of the uterus. So it's really important that there's enough around throughout the whole cycle. This is generally cycle days 15 to 28 in that perfect 28-day cycle. And like I said, your primary hormones that you see will be progesterone, and you'll also see that rise in estradiol. And then you have menstruation or bleeding. This actually overlaps the follicular phase because, as I said, cycle day 1 is the first day of bleeding. So menstruation and follicular phase are happening at the same time. But if no fertilization happens after 14 days, that progesterone will stop being produced and estradiol and progesterone levels will rapidly decline. That sudden drop in progesterone causes an increase in prostaglandins, and that stimulates uterine contraction and it stimulates the uterine lining to shed. Okay, and when menstruation begins, that marks the beginning of a new cycle. So you can see how it kind of all comes together here. You have in yellow, you have estrogen, which again, it's kind of low in those first days, really starts to rise around day 7. And you see this estrogen peaks right here, which signals the brain, hey, we're ready, get the LH going. And you can see that this estrogen peak absolutely coordinates with the rise of LH. So LH will follow estrogen in peaking by about a day. After LH happens, you've got ovulation the next day. So ovulation is marked by this black line right here. And once ovulation happens, you start to see this really big juicy rise in progesterone. But if pregnancy doesn't occur, it will drop off after that period of time. So let's talk about how to assess the menstrual cycle. So what hormones should we look at and why? Okay, we want to look at estradiol, progesterone, LH and FSH, which are made by the brain, and then your androgens, testosterone and DHEA sulfate. Now, there are other labs that I will mention, although they're not the focus of today's lecture. Things like thyroid hormones, the adrenal hormones, and the HPA axis, prolactin, a CBC, a complete blood count, and a metabolic panel, a pregnancy test. Whenever things are off, think about a pregnancy test as well. And then imaging as well. So we're not going to get into details about that, but I will say that they can definitely impact menstrual cycle function. We'll touch upon that a little bit later. So estrogen is responsible for development and regulation of the female reproductive system. I think about it as almost like our mother hormone. It's like our, it's like the Beyonce of hormones, estrogen is. It's made by the granulosa cells in the ovary when they're stimulated by follicle stimulating hormones. So if you look at this picture on the right, the ovary is filled with these primordial follicles. These actually develop in utero when the mother is in utero. So like when a woman's in utero and her ovaries are developing, all these germ cells or primordial follicles are developed. Over time, they undergo atresia or reabsorption. And then every cycle, a certain number of them get called up into development. It's about 15 or 16 for most women. So this kind of upper part of the ovary here is showing what's happening during the follicular phase. You start to see many start to grow. You can see that this pink lining are the granulosa cells here. These are the ones that make estradiol. And you can see it starts to get more juicy and there's more in number. And then right when you're starting to get that like really big juicy egg developed, the rest have kind of backed off and there's one that's stealing the spotlight. This is what will cause that surge in estradiol. At that point, estrogen also will feed back to the pituitary for continued release of FSH. It does have like a positive feedback loop until it hits that set point and causes the brain to kind of switch. And it has some important functions. It helps with maturation of the eggs. It also promotes thickening of the endometrial lining to get it ready for implantation. And it increases the production of cervical mucus and also changes the consistency of cervical mucus. So fertile mucus is that like egg white stretchy mucus. That's really driven by estrogen. There's lots of other health benefits of estrogens as well. So estrogen's critical for bone density, for muscle mass, and for synthesis of collagen. It's also for women in combination with androgens critically important for a strong libido. You might not know it also helps with insulin sensitivity. It supports neurotransmitter balance and mood, helps with weight management, which is why we see some women start to struggle even more with weight postmenopausally. It helps with sleep, memory, concentration, the health of our hair, skin, and cardiovascular system. So lots of benefits here. And you probably know this already, but these are the kinds of things I want you to really take away, is utilizing your skill set in collecting information from your patient and having that be the first step of assessment. So here are some of the most common signs and symptoms of low estrogen. You have hot flashes. We see that a lot postmenopausally or perimenopausally. Insomnia, night sweats, a low sex drive, changes in mood, brain fog, vaginal dryness. That's a really common sign of low estrogen, or a lack of fertile cervical mucus. So you might not have women who are complaining of dryness, but if you were to ask them about their cervical mucus, they might not really notice much of a change throughout the cycle, and that could indicate low estrogen. Also, joint pain and low bone mineral density are things you'd want to be thinking about low estrogen for. Now, I think that more commonly, if you're dealing with cycling women, you're worried about estrogen excess or estrogen dominance. These are some of the signs and some of the risks of high estrogen. First of all, high estrogen in a cycling female can be normal. So it doesn't always mean there's a problem. If estrogen is good and progesterone is also robust, that might be fine. And women, you might see it on a lab, but have a woman who's asymptomatic, and that does not require treatment. But some of the things we see are heavy bleeding, or cramping, or clotting. It's not on this list, but clotting too, which you can see because you actually have even thicker, juicier endometrial lining that gets sloughed off. This estrogen excess is also associated with fibroids and endometriosis, fibrocystic breasts or tender breasts in general, fatigue, mood instability, acne, headaches, and weight gain. So lots of different signs of kind of that estrogen dominance picture. Now let's shift gears and talk a bit about progesterone. So once ovulation occurs, which is kind of this step right here, then what you see is these granulosa cells that were making estradiol, they actually get transformed by luteinizing hormone from the brain. So LH, the same hormone that triggers ovulation, also causes these cells to transform. And then they actually do turn yellow inside the ovary if you are to dissect the ovary. And that's because of the high presence of lutein. But they luteinize and become this juicy corpus luteum. And this is the tissue or the cells that produce progesterone. Okay. And corpus luteum generally is like a ticking time bomb. It will make progesterone when it's healthy for 14 days, and then it will just disintegrate. So if you have women who are not maintaining their progesterone level, I always think about looking at the health of these cells. I know we love to jump to put women on progesterone, but if you are familiar with my practice, you'll find that I very rarely do, really only in early pregnancy, or if I'm trying to have what I would consider a Band-Aid approach before I fix what's really wrong. What's really wrong is generally issues with the health of these cells. And you've got to fix the health of cells through mitochondrial support, antioxidant support, good diet, good sleep, all the basics to get progesterone to be produced for the full 14 days. So progesterone predominantly serves to retain that thick lining of the uterus, allowing for implantation and pregnancy to occur. Now, if it does, the hormone HCG, which is the one women pee on the test for a pregnancy test, will actually signal for the corpus luteum to keep on producing progesterone. If that signal does not come forward, like a woman doesn't get pregnant, then the corpus luteum degrades, okay? Progesterone is also great because it supports sleep and mood and memory, and it helps protect against breast cancer, endometrial cancer, osteoporosis, and cardiovascular disease. Now, when it comes to progesterone, it's more commonly low in cycling women compared to high. High progesterone can be normal. It might just be at the end of that kind of bell curve of normal, and it can be asymptomatic when it's high. So slightly elevated progesterone is not normally indicative of some kind of problem, but some women do experience symptoms when their progesterone's too high. It's what we would think about for early pregnancy symptoms, because that's where these all come from. Massive fatigue, increased appetite, breast tenderness, bloating, and PMS symptoms. So if anyone in the audience has been pregnant before, you know what that first trimester is like, very much caused by high progesterone. The other one I didn't put on this list is constipation. Actually, high progesterone can be a cause of constipation in women. If progesterone is high, it's more commonly related to like insulin resistance or obesity, but there can be other causes, including pregnancy, congenital adrenal hyperplasia, fecal cell tumor, and some other causes. So most of the time it's normal, but you do want to make sure that none of these things are going on for your patients. Now, low progesterone is far more common in cycling women. You might see the fatigue, insomnia. I see a lot of anxiety in women with low progesterone, weight gain, which I think it shows up on every single hormonal imbalance list. It's just commonly associated with all hormonal imbalances. Infertility, because you don't have the ability to retain a lining. Low bone mineral density, although it doesn't have the same impact estrogen does. PMS, heavy bleeding, irregular bleeding, and breast tenderness. And those last two are the ones that I see most commonly, irregular bleeding and breast tenderness. So some other signs would be like spotting before their period for several days, or prolonged spotting or bleeding in the middle of the luteal phase. A lot of times that's due to progesterone not being quite high enough to really maintain the integrity of the uterine lining. Okay, LH, just briefly, LH and FSH are both made in the pituitary gland, LH through the second half of the cycle, FSH through the first. So this gets surged mid-cycle to trigger ovulation. I'd mentioned it already transforms the granulosa cells into corpus luteum, which make progesterone. And actually, this is typically measured on cycle day 3 still when we're looking to evaluate menstrual cycle function. Even though it surges during the middle of the cycle, it's rare that we're testing it at that time. The only way we would be testing would be to, be able to predict that ovulation is about to occur. Now, if you're working with women with fertility, an LH surge does not necessarily mean that ovulation has occurred. It means that the brain is signaling for ovulation to occur, but there are instances where women don't respond to that LH. So this is not a good confirmation of ovulation. Progesterone is better to confirm that ovulation has occurred. But we typically measure LH on cycle day 3, also with FSH, because LH can be elevated compared to FSH in women with PCOS. There's a lot that goes into that. There's genetics and low progesterone, but what can happen is the hypothalamus, which is kind of our master control, it dictates to the pituitary which hormone to make based on how fast it pulses the production of gonadotropin releasing hormone. Because GnRH is the same hormone from the hypothalamus that tells the pituitary to make LH or FSH. So in women with PCOS, the low progesterone keeps the pulsing to be too quick. And also genetics can predispose women to that. Then they end up making more LH. So you can sometimes pick that up on testing. FSH is most commonly run to either screen for PCOS in combination with LH, or to evaluate ovarian sufficiency, or to see if women are in menopause, which would be a measure of ovarian sufficiency. So you want FSH to be nice and low early on in the cycle, because what it's telling you is that the ovaries are listening and responding when the brain is only whispering. Okay, as the ovaries age or their quality declines, or their sufficiency declines, the brain turns up the volume on the FSH signal to try to get more response from the ovaries, and that's when you see FSH start to climb. Now, in literature, there's 100% specificity for failure to achieve live birth or pregnancy if FSH is over 18, okay? When women hit menopause, it could be in the hundreds, but you are gonna work with women probably in that in-between phase. Now, we might think of androgens as like quote unquote male hormones, but they also have critical function in females. So don't underestimate them. They are the precursors to production of estrogen and progesterone, and they're also individually critical for follicular development and egg quality. So testosterone is our predominant androgen, and in cycling women, it's made about 25% in the ovaries, 25% in the adrenals, and about 50% of our testosterone is converted from androstenedione in our fat. Okay, and believe it or not, in postmenopausal females, this shifts, and it's almost all adrenal gland production. So that's a huge change that happens in menopause. And androgens will peak in a woman's 20s and 30s and then have a steady decline afterward. But lots of benefits here: growth, muscle mass, stamina, libido, sexual function, healthy bones, skin, hair, fertility, cardiovascular health, mood, memory, and they also support estrogen levels, especially in postmenopausal women, because their estrogen is made really from the conversion from testosterone. High testosterone symptoms you might see would be like acne, greasy skin. It can be increased facial or body hair and a thinning scalp hair, and also mood disturbance, more like that kind of irritability, aggression, or anxiety. If testosterone's high, you want to look at DHEA, because those excess androgens are probably coming from adrenal production of DHEA. But if that DHEA looks okay, then your source of excess is probably from the ovaries. And some signs of low testosterone, we see this a lot in practice too: fatigue, weight gain, trouble building muscle mass, bone loss, mood changes, brain fog, and low libido. And then lastly, we'll talk just briefly about DHEA. This is considered a pre-hormone. Most of it does convert on to be more potent androgens or estrogens when it's in the tissues, but DHEA is made by the adrenal glands and the ovaries in cycling women, predominantly the adrenal glands, and then it gets converted in the tissues to become estrogen or androgens, okay? Lots of benefits of DHEA that really mimic testosterone because it is still considered an androgen. So similar symptoms of high, similar symptoms of low. Okay, let's dive into how to assess now that we're all on the baseline here. So don't forget symptothermic monitoring. This is your cycle charting, okay? So you've taken an assessment of what's going on with your patients. This is free. They can track this themselves. A lot of women who have menstrual irregularities are already tracking their cycles. So you can look at basal body temperature, which you can see kind of plotted out here, cervical mucus, which you can kind of see this chart here, and then cervical position. I don't often recommend women do, but some women do it anyway because the cervix will change position and it will feel different during different parts of the cycle. But on temperature shifting, what you're looking to see is kind of a baseline temp that then shifts to a new baseline, and the temperature will increase around ovulation. So this is an example of a non-ovulatory cycle where temps kind of don't form a pattern and they're a little bit all over the place. And with cervical mucus, what you'll typically see is you have menstruation when they're bleeding and then a few dry days, and then they'll start to have more cervical mucus production that will peak right before ovulation. Now, charting's great because you can gather info about the whole cycle. It's low cost, there's no blood draws involved. And I also like that it helps women kind of get more information about their cycle. And you can use this to support conception or contraception, or you can use it just to gather more information. You can pick up a lot here: late ovulation, no ovulation, a luteal phase defect, which is it's too short between ovulation and the menses, a lack of fertile cervical fluid. You can pick up hormonal imbalances, low progesterone levels, and you can even see if a woman has a miscarriage. Now, once you have that collection, let's move on to the juicy stuff with labs. So here's my kind of initial lab workup for women who are trying to conceive or where we want to evaluate their menstrual cycle. You're probably surprised in like this functional webinar to hear about serum labs, but if serum labs produce good information, especially if they can get covered by insurance, it's a great place to start. So I do like to run these basics. I look at ferritin and CBC because things like anemia can actually disrupt the menstrual cycle. Thyroid, I mentioned, thyroid is involved with master metabolism, and a thyroid being off will absolutely affect the menstrual cycle. CMP is a comprehensive metabolic panel, and you can see things here like liver function, kidney function, etc. I like to look at blood sugar. I do at least fasting blood glucose, which is part of that CMP, but I might also add fasting insulin. in a woman where I'm concerned that this might be an issue for her. And then I also always check vitamin D, 25 hydroxy vitamin D, because vitamin D being off can throw off the menses as well. But we're going to spend most of our time today talking about hormones. So day 3 testing for most hormones, day 21 for progesterone. Now, when you're testing, the kind of the key things you want to think about are you want to see day 3 estrogen, like generally between about 30 and 50 nanograms per mil. And there is a slide in here where all of my like optimal ranges are. So don't feel like you need to take notes on this because I summarize it for you later on. But if day 3 estrogen is estradiol is higher than 50, that can be an indicator of poor ovarian reserve. Okay, you want estrogen to be like not too low and not too high. Progesterone, you really would like to see above 10. That's measured 7 days after ovulation, which would be day 21 for a 28-day cycle. And so that you want to see, did ovulation take place, yes or no? But when that progesterone level is over 15, that's actually associated with a better per cycle pregnancy rate. So when we look at fertility, that's generally like the main purpose of the menstrual cycle. So that's the guide I like to gauge by to see is a woman's, are her hormones really optimized? Now, there's lots of ways that you can test hormones. There's serum testing, and then on the functional side, there's salivary and urine testing. And I do want to talk about this because I am a big fan of urine testing, thus my new affiliation with Dutch, and I want to be able to share with you why. So there are pros and cons to each of these. Like serum is great because it's standardized. It's normally what's used in published clinical trials. I find it really easy to communicate results with other medical providers because I'm an ND, but I'm always working with reproductive endocrinologists and OBGYNs. And if I send them a Dutch test, they don't always know what to do with it. So I like that serum is like kind of that common language between us. And they're often covered by insurance, which is huge. Some of the downsides are they're only single time points. And you might miss the critical measurement, especially if the cycle is off. So it can be a downside. You also have to have multiple blood draws, even to do basic evaluation with serum, and you still can't see the whole picture. And also serum's not appropriate with cortisol, and I like to take a look at the HPA axis, or if you have patients on any kind of hormone replacement, if the dosing has a significant up and down, like oral progesterone does, or estrogen gels and creams, serum is inaccurate. Now, saliva and urine are both relatively inexpensive, and it makes it easy to plot an entire cycle and see trends. Okay, so that's what the draw is there with those two formats. They can be at-home collection. It's so much more easy. Saliva, if you look at data, the best way to test cortisol is in saliva, but the data is not so great for reproductive hormones. It's okay for progesterone, and for estradiol, I really don't find it helpful. And that's why I tend to go with urine. Okay, I'm going to show you a little bit about reference ranges between salivary testing and urine testing, and I think you'll see more what I mean. But with urine testing, it's also validated in literature, and you can actually differentiate when it comes to cycling women and postmenopausal women, and saliva is not sensitive enough to even distinguish estrogen ranges for a postmenopausal and a cycling woman and tell them apart. And that's a big problem for me when I'm trying to assess testing here. Some of the cons with saliva is that lack of gap. So I'm going to show you that on my next couple of slides. And on the urine side, it's tough because you do still have to collect multiple time points, not often covered by insurance, but generally when I'm looking at saliva versus urine, for me, urine is a clear winner. So let's take a look at like what I'm talking about when I say you can differentiate between cycling and postmenopausal women. So let's look at just this kind of theoretically first. So ideally, what you would want to see for estrogen, estradiol, is that you have this like reference range for cycling women up here, and then you have a reference range for postmenopausal women because estradiol should be lower in women who are postmenopausal. And you have this space in between that separates a normal value so that if your patient shows up here, you know that they're high for a cycling woman, right? If they show up here, you know they're kind of normal for a cycling woman. If they show up here and they're a cycling woman, you know that's low because they're in the postmenopausal range. And what happens if they're here in the middle? This is where you have to kind of dig a little bit deeper to try to find out. But this type of conceptual lab reference range shows meaningful differentiation. You can tell whether a patient is in range or out of range. Now let's take another example where you have your premenopausal and your postmenopausal reference ranges that overlap, okay? And this is the case with most salivary labs. This isn't my opinion, like call the labs or look at the test results and you'll see this yourself. If you have a patient that falls here, there's a problem because they might be in the cycling range, in the postmenopausal range, or somewhere in between. There's no way to like differentiate between what a cycling and a postmenopausal woman looks like. Now, let me show you what I mean. These are like actual reference ranges. So these have been kind of normalized so that the base of the postmenopausal range is all set at 1. But these are 4 actual saliva labs that exist out there today. And you can see that they all have overlap here, okay? This one has such a huge overlap. In fact, this one here, the postmenopausal female reference range is actually higher than a cycling female, where, you know, we wouldn't normally expect postmenopausal women to have estrogen levels higher than cycling women. But in this salivary lab reference range, it says, yes, that happens. And then this one here still has this massive overlap. So what basically it creates this big murky area where if your patient comes in the middle of those, you don't even know really how to interpret it. Now, these are kind of the best 2 saliva labs here. This is Dutch testing, and this is serum testing right here. So you can see that urine and serum actually have a really big gap. And again, these are all normalized to show like comparative reference ranges. But what you can see here is there's still a lot of overlap here. Put these in here for you. There's still a ton of overlap with saliva, but with urine and serum, you can very clearly distinguish if a woman is like within range or like really, really low. Okay. So let's talk about my favorite functional lab for cycling women. It's the Dutch Plus and CycleMap. It's a combination test that's available on the Rupa platform. And this is like the grand pumbaa of Dutch testing because it really looks at everything and I absolutely love it. This is the summary page in the front. And you can very quickly look at estradiol levels, progesterone levels, and testosterone levels. So you get a quick view of all of the major categories of reproductive hormones. And then it gives you a summary of the adrenal hormones on this same page. I like to look at stress hormones when it comes to cycling because chronic stress, actually the HPA axis and the HPO axis share hypothalamic and pituitary function. And we know that chronic stress can impact the efficacy of the HPO axis, the hypothalamic and pituitary glands, but high chronic stress also influences the ovaries directly and the testes in men, where it actually changes the ability of the receptors to do their job or to listen to the brain's hormones. So there is a very direct connection between stress and the menstrual cycle. So I love that I get that picture here. In fact, for women who develop amenorrhea kind of later on in life, they typically look at your hormone levels, and oftentimes what they'll see is low LH, low FSH, low estradiol, and low progesterone. It's like the cycle shutting down. And even in conventional textbooks, the leading cause of that is stress, a big stressor. Okay, so if a big stressor can cause everything to shut down, there is a gray area before that where chronic stress can cause dysfunction. These are the other kind of key pages I look at in that test, and I'll walk you through it in a little bit here. But you can see the metabolism of progesterone, of androgens, and of estrogens. Whoops, I don't know if I can go back here. There is this organic acid summary page, which this is actually, I pulled this off of an older patient because it's missing a new one called Indican, which Indican actually looks at whether there's dysbiosis in the gut. And within the Dutch data, what we've seen and in the clinical literature is that when indican's high, indicating dysbiosis is happening, we actually see higher estrogen levels, which when we talk about estrogen detox, I'll tell you why. And then this test also includes a cycle map. So the cycle map actually plots 9 different time points across the menstrual cycle. Women might collect as many as like 20 or 21, I believe, at home. But then when they send them in, they actually look at the best data in order to be able to plot the curve for you. So it's pretty cool here. You can see how estrogen and progesterone change at different time points throughout the cycle. So how do I work up? This is kind of the takeaway here. First, you want to start with signs and symptoms. What are you picking up for the patient? And then ask yourself, are there patterns to these signs and symptoms? Are serum tests warranted to diagnose a problem? And then how can you further assess these symptoms of imbalance to get to the bottom of what's going on? So starting with signs and symptoms, I have like a hormone symptom questionnaire. These are some of the signs and symptoms that exist on that questionnaire. You could Google this and probably find 10 versions of this online, or just have this as part of your questioning. As you're doing a review of systems, asking about all these things that can influence or be influenced by hormone levels. When I say identify patterns to symptoms, consider whether there's periodicity to your patient's symptoms. Do they find that they have worse symptoms like right before their menses, or maybe at the start of the cycle? A lot of women get PMS, but then as soon as their flow starts, it's gone and they feel better. Other women get worse with their menses, like they might get headaches that are worse during their periods, for example, or symptoms around ovulation, spotting just at ovulation, for example. This might clue you in to what time in the menstrual cycle there's a problem and what hormones might be involved based upon what the symptoms are, and even when to test. So you might decide to do testing at a different time in the cycle. And actually at Dutch, the docs will help clinicians who have women with wonky cycles kind of figure out when the best times to test are. You also want to consider what makes symptoms better or worse, particularly like supplements, like if they have supplements to support estrogen or to support estrogen detox. I had a patient I'm going to show you the case for where the supplements to support estrogen detox made her worse, right? That tells me something. That tells me that, estrogen declining is a bigger problem for her. And you can look at that with like hormone therapies. I had another fertility patient last week that tried to do progesterone in the second half of her cycle, but felt absolutely terrible on it. And you know what? When we tested her progesterone, it came back high normal without supplementation. So she didn't need it. When she took extra, which she did on her own, it went through the roof and she had a ton of symptoms. So looking at those patterns can be really helpful to start to clue you into what might be happening. Next, I would say work up to diagnose. So for more serious symptoms, before you get into like hormone imbalance, it's important to rule out more serious causes. This is more than we can really talk about here today, but there are so many clinical algorithms that are available for free online that physicians can reference. And I would just say if you're not a physician, if you're a dietitian or another practitioner type who does a lot of hormone work, I'd recommend a referral in these cases versus trying to do it on your own if you don't have diagnosis in your scope, because you want to make sure nothing serious is going on. And there can be serious things happening that look like hormonal imbalance. This is especially important for any abnormal uterine bleeding. So really heavy bleeding, bleeding between menses, prolonged bleeding, where instead of 5 or 6 days, they bleed for 20, 10, 13, etc. Or for amenorrhea, where women have either never had a period or they've gone more than 3 or 6 months without one and they're not pregnant. And these exist. I'm not going to run through these, but I wanted to show you, like, this is a free one from the website of the American Academy of Family Physicians that actually guides you through the testing and diagnosis process. So if you're a healthcare practitioner that can diagnose, these can be super helpful to actually tell you exactly what tests should be run and when. This is one for secondary amenorrhea. So women whose cycles stop. You would do a pregnancy test, and if it's negative, here's the order where you might work things up and what you might expect to find. Here's another one. This is a nice one that looks at like amenorrhea and some of the major causes of it, and then what all of your test results you'd expect to see. So these exist all over the interweb, and you can find them on like really well-referenced sites. The American Academy of Family Physicians, ACOG, ASRM, which is reproductive medicine, and they do make them available for free. Once you've ruled that stuff out, let's talk about the patients who just have imbalance and we're trying to figure that out. Again, I start with those basic labs like we talked about earlier. And when it comes to the normal labs, another thing that I'm like really big on is actually looking at data beyond the lab normal. Okay, and I work with fertility specifically. So in order for people to have optimal fertility, we really need to make sure their labs are really great. And this kind of estradiol and serum, if you look at the reference range for an adult female, you can see the same kinds of problems that I described earlier with salivary testing, where there's these reference ranges that really overlap. You have here, like, there's this section of 85.8 to 166. Any measurement in there would be normal for a follicular, ovulation, or luteal phase, right? So here's your challenge, is like, if you have a woman that result came back, let's say it was another clinician who sent it to you, you'd have no idea what day they tested on, because the reference range kind of has this massive overlap no matter the point in the cycle. But every woman has a normal that's right for them. So we really want to look at more specific ranges, kind of that optimal range. And I'll show you on the next slide what my optimal ranges are that I use in my own practice. But here's another reason why I like cycle mapping, is that you can get multiple time points and see how things compare. Because a woman who is at 12.5 in her follicular phase, when you measure it, her ovulatory surge might be smaller, her luteal phase might be lower, and that might be her normal pattern, right? But if you were to measure a woman at this phase and she was at 166 and then her ovulation phase was 85, well, you have a problem there, because the relative height of the relative concentration of estradiol through the cycle really matters. This is like a handout that I give to my patients that has kind of the lab's normal range and then my tighter optimal range. And I wanted to give this to you to take home. You might actually need different optimal ranges for your own practice based upon the patient type that you're seeing. This is based upon fertility, which is really actually a pretty good measure, because good fertility generally we would believe would be good menstrual hormone balance. Okay, but you can see kind of my optimal ranges here. Okay, and then from here you'd consider your functional hormone testing. So I love Dutch testing. You can learn so much about a patient's hormones, about their hormone levels, detoxification details, their HPA axis function, markers for nutritional deficiencies and inflammation. So you've got a few options here. The Dutch Complete is like the flagship test. It's what we have most practitioners order. That includes the sex hormones, a cortisol curve throughout the day, and then organic acids. The Dutch Plus adds the cortisol awakening response, which is 3 time points in the first hour. It's like waking 30 minutes later and 60 minutes later. And actually in literature, it's really exciting because we're getting a lot more consideration for the impact of the HPA axis on overall health. And most studies actually don't look at the diurnal curve. What we're seeing is a lot more relevance of that cortisol awakening response. So they're really both important. And so I like to do the Dutch Plus because you get both of those. And then we have the Dutch Cycle Map, or the Dutch Plus Cycle Map. This is the most comprehensive option, and it's another favorite of mine for menstrual cycle assessment. Lastly, think holistically. Okay, hormones are like people. They have a really strong influence over one another. So imbalance in one hormonal system can lead to shifts downstream in others. So if you have hormonal imbalance, don't think just about testing those reproductive hormones. Think outside of it. Sleep, stress, the HPA axis, the thyroid, metabolism and blood sugar, inflammation. And especially if you run testing and things still don't really add up, you might have to think outside the box for what could be driving those imbalances. So let's talk more specifically about maximizing use of the Dutch test. So why the Dutch test? First of all, that gap we talked about. The test is very sensitive, so you can actually distinguish between normal levels for cycling and postmenopausal females, and this is especially marked with estrogen. Their test methods are validated. There is so much, and this was actually impressive and something I wasn't aware of. There's so much published peer-reviewed data showing the validity of the testing, but also the clinical relevance of the testing. There's been some cool posters published, and there's early data that we have internally that we're working to publish showing that actually elevated androgens on the Dutch test could be predictive for PCOS, which is pretty cool. And that's urinary androgen metabolites that can be predictive for PCOS. There, we also have shown that when you give women hormones, you can measure the difference in a kind of a linear, appropriate fashion in urine. There's really cool research out there. I also love that it's very easy collection for the patients. And they provide really amazing support like education, trainings. We even just launched mentorship with our clinical consultants, which will be available to sign up for on the website very soon in the portal, and one-on-one consultations. Now, when we look at the Dutch test, I like to look at page 3 first if you're looking at a Dutch Plus or a CycleMap/Dutch Plus. And the first thing that I would look at would be the total E1, E2, and E3, which are located right here. These are your 3 main forms of estrogen and the different levels of them. Okay, so we actually use this like dial fan gauge or this dial gauge to show you like the upper and lower end of normal. And they're kind of normalized so that when you're looking at progesterone, they're generally, this person's probably at like the 40th, 45th percentile in the reference range, where their estradiol, let's look at this one here, is probably in the 60th or 70th percentile. So you can see there's a relative estrogen excess here. Then you can see phase 1 detoxification, which is represented by the green, red, and blue lines. So phase 1 is breaking it down into kind of temporary intermediates. We don't have time to go through this today, but there are Rupa webinars on this, and actually Dr. Carey's bootcamp goes into this in super detail. You can see phase 2 right here, this kind of methylation step with COMT. And now you can actually see, I didn't put it on here, but you can see, you'll see another line here with indican, which looks at dysbiosis, which can affect phase 3 of detoxification. Okay, so then once you're looking at the estrogen, the metabolites, you can then look at markers for inflammation and oxidative stress, some of these underlying drivers for hormonal imbalance. So you can see things like vitamin B12 and B6 deficiency, or low levels of glutathione, which is a really important antioxidant. If you have a patient with low progesterone and this marker is off, showing their glutathione might be low, that could be part of the issue for them. I also love to look at this oxidative stress marker called 8-OHDG. This is a marker for DNA damage. And when this is high, that actually can demonstrate too much oxidative stress and a lack of antioxidants, which again is an underlying cause of low progesterone. You can look at HPA axis function. So you can look at it first on this first page here. I keep losing my cursor on my screen. Here we go. This is the cortisol awakening response. And then you can see the rest of the day here, but you can see waking plus 30, waking plus 60. This is actually not a good response. What you should see is it spikes and then starts to come down by 60 minutes. It should be here, up higher like this, and then down. So this patient, if we had only done like 1 hour upon waking it down, it would have looked pretty normal. But when you can see that this car is off, it actually shows you there is some problems with their HPA axis. So let's just kind of end with a case here in the last few minutes. This was a patient that came in with unexplained infertility. She'd been trying to conceive for 1 year. Her cycles were pretty regular. She bled for 5 days, but they were on the short side, only 26 days. And she had really heavy bleeding with clots, pretty severe cramping on cycle days 1 and 2. And when she came in, she said, my doctor thinks I have endometriosis because of heavy bleeding, severe cramping. Her sister had infertility and had been worked up and was diagnosed with endometriosis. So there is a familial component. And she'd also had imaging of her fallopian tubes, and they found that one was blocked. And so they assumed that it was due to endometriosis wrapped around her fallopian tube. So this is the information that she came in to me with. They had a really clean diet and lifestyle profile. Her partner was within normal limits. So the first thing we did was look at lab results. And so I put in here, these are kind of the optimal ranges that I'm looking at for women based on that chart that I provided to you. Her estradiol was a little high compared to that range, which is what you'd expect with endometriosis as well. Her progesterone looked fine. That looked really good. You can see that's quite good, 15.79. So over 15 is optimal. Her thyroid looked good. Her androgens looked good. So when I ran her blood work, I said, yeah, this does look like elevated estrogen as well. So it's really possible that it could be endometriosis. We talked about doing functional testing, but she didn't really want to do that at first due to cost. And so her first plan, we just focused on improving her estrogen metabolism and improving her egg health and helping to get her cycles a little longer. So when it came to estrogen metabolism, I put her on DIM and indole 3-carbinol and increased fiber to help with elimination. And her cycles actually got worse. They got shorter. And she felt terrible, right? And so I knew that we'd gotten something wrong. We had to dig a little deeper. So then I was able to convince her to do a cycle map, looking at her cycle through the whole, plotting points through the whole cycle. She was really resistant due to the cost, but we ended up doing that. And what we found was her estrogens were like really on the low side already. Okay, this is not really consistent with endometriosis, although this test isn't diagnostic of it. But what we saw was she did seem to kind of peak and have her ovulation early, which was consistent with her short cycle. So her luteal phase length was okay. And her progesterone looked all right, but not stellar. But her estrogens were really on the low side here. So this is the same graph. This plots it as if it were serum. We can convert based upon the metabolites to what the serum measurements would look like. And what's really interesting when you look at that is that I had done her blood work, if you remember, on cycle day 3, which is right here, and on cycle day 21, which is right here. And if you look just at these measures, her progesterone looks totally normal. And look at that, her estradiol looks totally normal. It's right in the middle of the normal range practically, which is why I couldn't see the rest of the cycle was the problem. So you can see here, it really only peaks just above 200 rather than peaking up as high as it should. And so then we looked at her metabolism. She had a cortisol rhythm that was way off that we had to work on. And her estrogens overall were actually quite low compared to her other hormones. So when I had put her on DIM, DIM is great because it assists with conversion to the healthy pathways through detoxification, but it also lowers total estrogen in circulation, which was not a good choice for her. And it puts more stress on her phase 2 detox pathways, which you can see right here, which were already a little bit slow on that low end here. So although it was a good, good first guess, it was the wrong guess for her. And in the end, what we had to do was actually give her more support for phase 2 to kind of get that moving a little bit more efficiently and support her overall estrogen rather than putting her on things that would reduce her estrogen. So I had her on herbal tinctures to raise her overall estrogen. And then we focused on metabolism instead in order to get things metabolized more effectively. And about 3 months later, her cycle had lengthened to 28 days and she was able to conceive. So we were not able to do that with serum testing alone. And you can see how you could layer on those testing methods to really get a more complete picture for a patient, because seeing a single time point of estradiol, for example, is not enough for you to really build a great treatment plan out of. So thank you so much. I would be happy to answer any question.
All right, I am back. Sorry, I lost the Zoom thing for a moment. That always gets lost. Amazing. Thank you so much for that fantastic presentation, Dr. Smeen. We have no less than 1 million questions to get through.
I know, we move so quickly. So remember, you get the slides.
As many as possible. But if your question doesn't get asked or answered, I apologize. It's not because we're missing you. It's more so just that we have so many to get through. So let's start from the top. Do you test for 4-methoxy E1 and E2? And if not, why not?
Do you mean on the Dutch test specifically?
I believe so, or maybe just in practice as well.
So the only 2-methoxy E1 is tested, and that's really just as a marker. It's like the best marker for that methylation step. So it's not considered necessary to test for all of those metabolites, but the 2-methoxy E1 is tested.
Perfect. Can both low estrogen and high estrogen cause weight gain?
Yes. Isn't that terrible?
Yeah, that is terrible. What should be checked if IVF keeps falling?
Oh, keeps failing? So, gosh, that's a super complex question. The 30-second answer is that it depends where it's failing. So with IVF, it's actually nice because you get a little bit of insight into every step of the process. So if, the first step would be retrieval, right? So you want to see how well a woman responds to medications and how many oocytes get retrieved. Okay, those also get graded, so you can see the quality of the oocytes retrieved. So if that's a bad step, it's not going well, then you'd work on egg quality. The next step we can look at is embryos and blasts and the quality of those blasts. That is where you add sperm into the mix, into the picture. So if things look great on the egg quality side, but the blasts aren't normal or they're not genetically normal, that would lead me to think more about male health and maybe doing more testing on sperm or things like DNA fragmentation. And if they're getting genetically normal embryos, but they're not getting pregnant, the transfer is not successful, that's when we look more at things that affect the health of the uterus, which could be inflammation, low-grade infection. There's a lot of new data coming out on microbiome disruption within the vagina and the uterus, clotting disorders, autoimmune disease. There's so many things that can affect transfer rates. So we try to narrow down based upon each step of the process in IVF exactly where the problem is.
Perfect. What are your thoughts on using hormonal creams depending on the time and cycle stage of life?
Well, I think postmenopausally bioidentical hormone replacement can be like life-changing. So I'm a big fan of it used. I also grew up in the era of like use as little as possible for as short a time as possible. And that's the approach I tend to take. Now with cycling women, it kind of depends on their goal and outcome. If they are trying to conceive, they might or might not be appropriate for the patient. If they are like trying not to conceive, again, you might think about like contraceptive methods or the impact of bioidentical hormones on whether that can be effective contraception, for example. And then if it's symptom management and the patient's not trying to get pregnant, you have a little bit more leeway with the use of hormones. So they can be appropriate in some patients, although I would say that the menstrual cycle, if it's disrupted, is a sign of another problem. So it's not just random. So trying to figure out the cause is always my preference.
Absolutely. Imbalanced sex hormones. Can it affect a hard to regulate thyroid hormone level?
We normally see more that the thyroid impacts reproductive hormones, but I suppose if things were out of balance enough, you could have a thyroid impact.
Great. Do you have to have the patient run hormones exactly on day 3 and day 21 of their cycle?
It's desirable because that's where the reference ranges come from. But you don't have to. I mean, you can like logistically test any day of the cycle. So if you wanted to see where estrogen was in the second half of the cycle, you can measure it on day 21. You can measure it on any day, but for the most research is conducted with testing on those specific days.
Yeah, that makes a ton of sense. And just a quick note, everybody, I know we're at the top of the hour. Dr. Smeeden is wonderful enough to stick with us for a few more minutes. So we'll again get through as many as possible. So jumping right back into it. Oh, and just also a quick note, if you do have to jump, as I mentioned throughout in the chat, we always record these. So keep an eye out for a recording in the coming days, as well as with the slides. So the next question, do you ever run more specific thyroid labs initially, or only if TSH is abnormal?
I like to run the whole panel. So I might have had a slide that said TSH, but what I meant by that was thyroid. So I'm running usually TSH, which is kind of the most well-recognized marker, free T3, free T4, sometimes reverse T3, and almost always thyroid antibodies. Because I'm dealing mostly with fertility patients, and actually elevated thyroid antibodies, even with a normal TSH, there's higher rates of infertility due to possibly some crossover on the autoimmunity side. So I take a different treatment approach if there's elevated thyroid antibodies. That might not be as relevant for patients not trying to conceive, but I would still want to get a broad look at the thyroid function.
Absolutely. When is a good time to check labs for hormones if a woman is having irregular or no periods for many months?
That is such a great question. And that's another example of when I would always use a cycle map, because if you don't know when a woman's ovulating, it's the same for women who've had partial hysterectomies where they have ovaries but no uterus, so they're not bleeding anymore. They don't have that menstrual bleed to kind of tell them where they're at. And if you're in that situation, if you call the Dutch team, they'll actually help you gather the right days for your specific patient, because it's different for each and every one, but it can be a little bit tricky to try to pinpoint, exactly what days to test.
Yeah, absolutely. It's always nice to have the lab being able to help you as well.
Yeah, and they do a lot. Like there's actually like a physician looks at every single report that gets published before it goes to you. So one of the doctors on our team reviews every test. So if you had a patient like that where we did this period of 30 days and maybe they tested at the wrong period of time, they'll actually like plot the data properly to show properly on the curve for you. So you can have, the start date will be different and they'll plot it. So they'll like rearrange the sample order. I mean, they're really great at trying to help you get usable data for your patients in those circumstances where things are kind of wonky.
That's amazing. What thermometer do you recommend for temp charting? How do you suggest tracking the charts, paper or electronic? And what's worked best for you in your practice?
It totally depends on the patient. You can buy like a $10 basal body temperature thermometer on Amazon, and they're all going to be pretty accurate, The only thing I recommend is that you find one that will save the prior measurement when you turn it on again. That way, if a woman has to wake up on a weekend, take it an early temperature, they can take it, put it down, and then when they wake up, turn it back on and record the temp. But now there's all kinds of things like these. I have an Oura ring that tracks temperatures now. There's these like Ava bracelets. There's all these different devices out there that simplify tracking. And so if I really like those so that patients don't have to obsess over it, it kind of just does it for you. So that would be probably what I would recommend. There are so many apps too, and I generally prefer my patients use apps for a couple of reasons. One, they're not going to lose it. It's right there. It's easy to take with them. They can also export the data and send it to me. So it's a great way to share with your provider.
Yeah, that's great. We here at Rupa as well are big fans of the Oura Ring.
Mm-hmm.
So this one, I had a miscarriage in May, and I'm sorry to hear that for whoever wrote this question is. My cycle came back in July. How long do you recommend to wait before they do a Dutch test?
I would, after a miscarriage, generally, I want a woman to have one kind of normal cycle, or maybe it's not normal, it might be long, but like one bleed that's not the miscarriage before you would start retesting. So I'm so sorry about your miscarriage. If you had that in May and you started your next cycle in July, then I would say that kind of July cycle, you would want to wait till August when it ends, and then you could test that next August cycle.
Yep. Is perimenopause or menopause possible with good hormonal labs and no symptoms?
Oh, like, is it possible to go through perimenopause and menopause with no symptoms? Absolutely. In fact, a lot of non-Western civilizations like didn't know what menopause was. Like if you study native tribes or like in Africa, even still that live a traditional lifestyle, they like don't recognize menopause. It is completely a modern day symptom picture. So that just goes to show you probably the impacts of like HPA axis dysfunction and environmental toxicity and all that stuff on our hormones, because, you know, absolutely it goes when women don't even know what happens except their periods stop. And I'll just like to say for the record, I wish that for all of us on the call today. I wish that for all of us.
Wonderful. What are some natural supplements that you use to treat perimenopausal women with low testosterone, progesterone, or estrogen?
Oh my gosh, that's such a humongous question because it's like every hormone and they're all going to be different. So with perimenopause and menopausal symptoms, my biggest concern first and foremost is to support the woman's symptoms to help her be comfortable and be good. And this is like the only time in life that I would say that. And the reason for that is that hormones will be shifting, right? So what's appropriate for a woman today might not be 30 days from now because hormones are naturally in a state of flux. The most important thing to me is like, let's make sure your hot flashes aren't bothering you so you can still sleep through the night, things like that. So it is a natural transition. I don't think women necessarily need hormone replacement, or you don't need to support estrogen. If she's in that asymptomatic group, that's okay, unless she has a risk of like bone loss or something like that. But there are so many natural products out there. I would say like shoot me an email or contact me on Instagram, and I'm happy to send you like a list of some of my favorite products for that.
Perfect. If a woman has anovulatory cycles, would you still run a Dutch test, or would it only be useful for women that you know have ovulated? And if so, how would you test, or when would you test? Excuse me.
Yeah, so it can still be really helpful because you can see a little bit about their hormones, especially in the follicular phase, to better understand why are they not ovulating. So it could be that they're not raising estradiol appropriately, which is required to trigger LH and trigger ovulation. You might see that happen. You can also take a look at hormone metabolism. So you would still be able to glean information. Again, I would say for those like wonky collection times, you can call and we can help you like guide to do the best instructions for your patient.
Great. And that kind of leads to the next question. Other than what's on the Dutch test prep instructions of what to avoid, any other factors of progression of disease that can somehow throw off the accuracy of the Dutch test?
Like across all conditions. Yeah. I mean, we see things all the time. Like there's people that will see Dutch test reports and say this could potentially be Addison's, and we'll like include that on the report as like a note that we add on there. So there are disease states that can influence the results, absolutely. Like I said, they all get reviewed by clinicians. So we try to put commentary on there, even some things like contamination. So one big, probably the most common one we see is like topical steroid creams, just ones that you buy over the counter, like an anti-itch bug cream. People don't always think about that as a hormone, but it will show up with like high cortisone and high cortisol on the test because it is like an anti-inflammatory steroid. So there are times where we can see things really elevated that look off, and we will put that comment on there for you to like double check. So I would say medication contamination and disease states, yes, definitely.
Perfect. How do birth control pills and other methods affect the accuracy of the test?
We don't recommend testing when women are on birth control because they're not undergoing natural production of hormones. You would be just testing the outcomes of birth control pills, which you don't really want. You can still see some estrogen detoxification, but it's really not so useful for women who are on OCPs. So I would recommend they get off of them. Again, go through one cycle off of them and then test.
Sorry, folks, I'm just cycling through all of these questions because there's some big ones which would take up, unfortunately, we wouldn't have enough time to go through all of them. And I'm finding some ones that might be just little quick hitters. How often should folks repeat the Dutch test?
That's such a great question. I like my patients to do it like 6 months after intervention. So that, it's generally 4 to 6 months to see cycle changes or to see the therapeutics you use have an effect. So that's when I would be repeating, is generally around 6 months.
Perfect. What tests and when would you perform them? If a patient had spotting for a few days, then nothing, and then their flow actually began.
So that would be
the flow.
Yeah, that would be a great opportunity to check progesterone levels on cycle day 21, or consider that cycle map where you'll see progesterone through the whole second half of the cycle. Because usually that spotting before even the stops and starts is related to progesterone not being produced enough.
Perfect. How do you use the Dutch test for menopausal or premenopausal or near menopausal, women with to help with their symptoms?
So that's more than we could cover today with cycling, which I know you saw how packed the presentation is, but postmenopausal women are the group that are like the most common patients to be tested with the Dutch test. So there's a lot of reasons for this. It's a great tool to help monitor HRT. So if you're doing hormone replacement therapy, it's awesome as a baseline, and we can help, provide you the education to help you understand how you can utilize it to monitor. On the website, or Josh, you guys probably have this on the Rupa site too, they made this really awesome chart on hormone therapies and how to monitor them, because the Dutch test is not good for monitoring for a couple of things. And it depends upon the hormone and the type of application, whether it's a cream, a gel, a oral, or, a pellet or an injection. Sometimes the Dutch test is helpful and other times it's not. So refer to that chart for your specific patient, and you can get really clear guidance on the best times to use saliva, serum, or urine.
Beautiful. We have time for a couple last questions. Can you please talk a little bit about SHBG and its effect on fertility?
Yeah, so sex hormone binding globulin is essentially a carrier protein. And for most hormones, like testosterone, for example, the majority of testosterone is carried around by sex hormone binding globulin. So only a small percentage, like 1 to 3%, would be free and be bioavailable. So if sex hormone binding globulin is elevated, what that can do is it can cause more of your hormone to basically be tied up. It's like packaging it up in a box so that it can't be played with, like a toy at the holidays. So, sex hormone binding globulin is important because if it's elevated, you might find low hormone levels in impact, like in efficacy. You might have symptoms of low hormone levels. Even if you looked at, like, if it's testosterone, for example, total testosterone, which looks at bound and unbound, might look normal, but they have symptoms of low testosterone. That's when you might look at sex hormone binding globulin to see, is it elevated? Is that part of the cause?
Perfect. How does estrogen dominance contribute to ovulation?
To anovulation?
Yeah.
So estrogen dominance wouldn't necessarily cause anovulation, because as long as if you're making estradiol and it's spiking, you will hopefully hit that set point to trigger an LH release. So we don't typically associate estrogen dominance with anovulation. There would be something else going on in addition.
Perfect. I've got a little bit of a layup question for you here.
Okay.
What's your Instagram handle?
That sounds like an easy question, but I'll probably get it wrong. It's hello_fertility.
Perfect. I'll put that in the chat, and hopefully I don't mistype it. Perfect. So folks, those are all the questions we have time for today. Dr. Smeeden, any last words that you want to get out there to the folks?
I think just like help these women. I mean, I think abnormal cycles is a sign of something wrong. And this is a patient population where their OBGYN might rule out disease and then be like, things are fine, just get on a birth control pill. But women are suffering. Oral contraceptives and overriding our hormonal system shouldn't be the only option. And in fact, that situation is what made me want to become a naturopathic doctor, because we have so many tools in our toolkit. And maybe we'll have to come back, Adrian, to talk about like treating the abnormal menstrual cycle. That's like part 2 to the assessment phase.
Yes, you're always welcome here, Dr. Smeeden. You know this.
Thank you.
Amazing. Well, thank you so much for your time. And thank you to everybody. I know that we went over time today. And if you're able to stick around for another 15 minutes or so, what I'm going to do is actually walk you through how to order this test directly on Rupa Health. So I'm going to go ahead and share my screen and we'll be able to walk through everything. You're going to hear my dogs barking here, but disregard. So let's talk a little bit about Rupa Health. Rupa Health is a functional medicine lab platform. We're designed with the idea in mind of making life easier, specifically when it comes to lab testing for really everybody involved. And that includes you as a practitioner, your patients, and even the labs. So let's talk a little bit about how we do that. So we are as I mentioned a moment ago, functional lab platform. Within Rupa Health, you're able to order from 30 plus labs, over 3,000 different tests, all in one place. So including, of course, Dutch, but among those, 29 other ones, right? So we have not only just your Dutch tests, but we have GI tests available. We have even blood tests, genetics tests, all here. And so now, instead of having to create separate accounts or go to all your different accounts to place all your orders, you have it all in one place. So streamlining that process to not only order, but also track and manage all of your results. We integrate with a number of EHRs as well, including Practice Better, including Elation. We just signed on with Serbo, so keep an eye out for that. And so now not only will you be able to place all these orders, but your results will actually flow directly into your EHR now as well. The next important part about Rupa Health is we'll actually manage the patient experience as well. So as soon as you place that order on Rupa, we'll effectively take it from there. We can manage billing directly with your patients. We offer multiple different payment solutions, including HSA, FSA, and even a 3-month interest-free payment plan. Beyond that, we'll drop ship the kits to your patient. We'll walk them through instructions on how to take the test, as well as handle anything like specimen issues, coordinating phlebotomy, ultimately things that would take time out of your day. But that's enough of me talking. Let's actually show you how it all works. To start an order on Rupa Health is simple. You just need your patient's first name, last name, and email address. From there, it'll take you directly into your order screen, which is also customizable as well. You can hop up here and you can create custom bundles. You'll see here we have Dr. Smeeden's fertility bundle. You can go ahead and have one click and have all of those different tests added into your cart straight away with one click from any lab. Below that, you have individual tests that you can put on your favorites list. So if I want to order the Dutch complete test, I have that available for me right here. But also if I want to order maybe a Biome FX test or a Great Plains test, right? I have all of these different tests available at my fingertips without having to go to each individual lab to order them. And down below, if I am looking for a specific test that's outside of my favorites, I have the access to it straight away here. From there, if that's it, it really is as simple as clicking send a patient. And that's how you're able to order from 30 plus labs all in one place right here on Rupa Health. Now let's talk about some important things that are available here on Rupa to help customize your order. You can do things like scheduling an order out in advance. So if you do want to retest your patient and have that automatically scheduled and sent to retest 6 months down the line, you can schedule that here on Rupa Health. Our pricing, we offer wholesale practitioner prices. So what that means is you're getting the same prices that you would get if you were to be working directly with the labs, right? So those are the prices that we offer here at Rupa Health. The way that we generate our revenue is we charge a flat 7% processing and ordering fee on each order, okay? So take note of that. That is the only way that we generate our revenue here at Rupa Health is through this 7% processing and ordering fee. If you do want to add things like your own custom fee to it, for example, an interpretation fee, you can add that on our platform and we'll go ahead and charge that directly to the patient. You do as well have the option of paying for the tests yourself here on Rupa. So if you want to be able to order a test or pay for it yourself and bill your patient separately, that is an option here. You can add notes for the patient, notes for Rupa, as well as any ICD-10 codes are available as well. If that's it, you go ahead and click send a patient. Now let's talk about some important topics or important details here on Rupa Health. Now, currently, in order to place an order on Rupa Health, you do need to be within the United States, or rather your patients need to be located in the United States. The 3 states we do not operate in are New York, New Jersey, and Rhode Island. But we actually just released a really, really amazing product, and that's called physician authorization. So if you are a practitioner whose licenses or certifications may limit your ability to be able to order some of these tests directly from the labs, through Rupa Health, we actually have that program available. And so now through physician authorization, you can order those tests directly on Rupa Health, and we'll have a signing physician available to actually place those orders on your behalf. So it opens up the ability for really any practitioners whose licenses and certifications might have limited them before to be able to order these tests, to be able to order them through Rupa Health. And so if you are interested in learning more about that program, I'll share my contact information, and I'd love to talk to you a little bit more. But quickly, what I'm going to show you is just what it looks like on the patient side of things. So this is what I like to call the second pillar of Rupa Health, and that's the patient experience. So as soon as you place that order on Rupa Health, here's the timeline. Your patient will receive an email from us. The kits will be shipped out directly to your patients within 24 hours of payment. We'll send over instructions and FAQs walking your patient through how to take the test. We'll follow up with the patient to see if they do require any support, and then you're emailed as the results come in. What does that all look like? I'm going to zoom in here. That way we can all see. So once you place that order, your patient will receive an email that looks just like this. They'll say, hey, these tests have been ordered from you by your practitioner. We'll introduce who we are, and then we'll go ahead and highlight the different payment options that we accept. We can accept credit, we can accept debit, HSA, FSA, as well as that 3-month interest-free payment plan. From there, we'll highlight the different information, any charges, and we'll collect the necessary information to complete the order with your patient. From there, we will follow up with them and let them know, hey, these kits have been shipped out, and then we will send an email that looks just like this. This email will provide instructions on how to take each test, walk them through how to fill out the requisition form, and if it does require a blood draw, we will give them options to plan and schedule their phlebotomy. If they need anything, whether it's support related or, hey, maybe I just want some additional options where I can get my blood drawn in my area, they'll reach out to our team and we will facilitate that support on your behalf. If it's anything medical related, no worries, we will go ahead and send them back your way, but we will take care of any general support when it comes to this lab testing. On the right-hand side, you can see instructions that we've created. So very thorough instructions, but also extremely comprehensive, but user-friendly, right? So they can click through the different sections, see what's important to them. All the necessary information on how to take the test will be available in there. But again, if they do have any questions, they can reach out to our team. From there, we'll follow up with them, and then you're notified via email as your results come in. You hop back right into Rupa Health, into your main dashboard, or into your EHR if we integrate with them, and you're able to view those results. But let's take a look at what it looks like when you're tracking your orders. So right in your main screen is where you're going to track your orders. You can go ahead and search by patient. You can filter by status of your different orders. You can see all your statuses here. And so I can open up and say, hey, here's a test that I sent to John Smith. It's from 4 different labs, 4 different tests. I can hop in, I can say, hey, the sample arrived at the lab on this date. I can expect my results on this date. Once they're in, I can download them. I'll be able to send them to my patient, as well as I can even schedule a clinical consultation with the lab that I'm ordering from. So this is something that Dr. Smeaton touched on during her presentation, is that Dutch is available to help with clinical consultations and provide resources to practitioners. Through Rupa Health, you're not losing any of that. You're actually still able to schedule time with the labs that you are ordering from directly through our platform. So what I've shown you so far is how to place your orders, as well as track your orders on Rupa Health, how to get your patient experience taken care of. The last thing I'm going to show you here is education. So this is what I like to call the third pillar of Rupa Health, education. So we all just listened to an amazing presentation by Dr. Smeaton, but that's one of many that we do, right? So you're able to hop in here. You have access to the whole catalog and library of previous classes that we've done in the past. So you're able to hop in here, watch them. You'll have access to the slides. Additionally, you can sign up for future ones. And if you are interested in getting more of a deep dive, we don't just do free live classes, we actually do paid boot camps as well. So with Dr. Carrie Jones, who's our amazing head of medical education here at Rupa Health, you actually have access and the ability to sign up for paid boot camps, as well as an article, a magazine that we have here. We have a ton of educational resources available for you here. And so with that, y'all, my name is Adrian Martinez. I'm going to share my contact information here in just a moment. But as I'm doing that, I think there was a few questions that came in. And so I do have a few minutes left, and I will go ahead and walk through and see if there is any questions that I can help answer as we're going through this. Some of these Instagram handle, if you want my Instagram handle, I'm more than happy to share that as well. All right. Happy to reach out to you, Darcy. More than happy to. I'll go ahead and save that. But it looks like there's actually some really good just conversation happening in here. So doesn't look like there's really anything for me, but if you do need anything, here's my contact information. Again, my name is Adrian. I'm the head of practitioner partnerships. My email is just adrian@rupahealth.com. There is my phone number. Keep an eye out for an email coming your way in the next few days, along with that will include the recording and slides. And just thank you so much for joining us on this Wednesday. Looking forward to seeing you next week. We do have these live classes scheduled up until February of next year. We're already booked out. So if you are interested, again, you can find them all on rupauniversity.com, or just sign up for Rupa, and I'll be your point of contact with that. So thank you all so much. Darcy, I'll be talking to you soon. Bye, everybody.